Well, hello, everybody. Welcome to this conversation on healthcare, coronavirus, and the church. My name is Travis Pickell. I'm the Associate Director of University Engagement at Anselm House, and just really pleased to have everybody joining in today for this important conversation. We're pleased to be joined in hosting this conversation by two co-sponsoring organizations. The Carver Project is a initiative at the Washington University in St. Louis, helping Christian faculty to serve and connect church, university, and society. And the Theology, Medicine, and Culture Initiative at Duke Divinity School is our second co-sponsor. The TMC program helps scholars, clergy, and practitioners to reimagine and re-engage contemporary practices of healthcare in light of the Christian tradition and Christian practices. If you want to learn any more about any of the co-sponsoring organizations, I invite you to please click on the links that have been dropped in the chat and follow up with that. We've invited our panelists today to speak about the challenges and opportunities the coronavirus has presented to healthcare and public health institutions in America today. Some of these challenges are medical and scientific. For example, how do we prevent and mitigate the transmission of the virus, or how do we allocate scarce medical resources? Other problems are more social or systematic. For example, how does coronavirus death rates correlate with racial and economic inequalities? At another deeper level, however, we're also encountering deep-seated questions related to the meaning of disease and illness and suffering and healing. And we're also focusing on our attention on addressing spiritual needs and emotional suffering in addition to medical and physiological suffering. Our conversation today will focus primarily at this third level, but also touch on the others. We're really interested in exploring the relationship between the medical and the spiritual frameworks, and especially exploring how coronavirus has highlighted certain tensions and even possibly connections between the two in our time. So at this point, I'd like to introduce our panelists. First, we welcome Elizabeth Diaz. She's the National Faith and Values Correspondent at the New York Times and a recent winner of the American Academy of Religion's top prize for the best in-depth reporting in religion and the Renner Award for Excellence in Enterprise Reporting in Religion. Elizabeth, thank you for joining us.
Glad to be here.
Next, we're pleased to welcome Dr. Ryan Anteal. Dr. Anteal is a pediatric surgery fellow at Washington University School of Medicine in St. Louis. And Ryan also writes and publishes widely in medicine, ethics, and culture. Ryan, thanks for joining us.
Thanks so much for having me, Travis.
And finally, I'd like to introduce Dr. Daniel Hall, who, in his own words, carries around a stethoscope and a stole, or a white coat and a white collar, as I'd like to say. Daniel Hall is a surgeon and professor at the University of Pittsburgh and also an ordained priest in the Episcopal Church. Dan, welcome. So as we jump into our questions, first, I'd like to invite any of you who are joining us to participate in the conversation today. You can utilize the chat function to talk to the panelists or one another. And you can also utilize the questions tab at the bottom in order to submit your questions. And we'll try to get to as many of those as possible at the end of our time today and our time for Q&A. So the first question I want to start with is going to be directed at Elizabeth. So Elizabeth, many of us have read and were moved by your article, The Last Anointing, which was, to my mind, a stunning piece of both journalism and religious reporting, but also photojournalism. For those of you who haven't read it, the article tells the story of a special team of clergy in Boston, Massachusetts, who had been deployed to minister to those who were dying of COVID, especially in the early days. I would love if you could just start our conversation by telling us a little bit about how you came to write that article and what you learned in the process.
Sure, and thank you for your kind words about the story. And yes, the photographer for the story is absolutely incredible, Ryan Christopher Jones. And the piece, was a real collaboration between photojournalism and, normal reporting, normal old school, just the writing reporting. But when the pandemic hit, my colleagues on the national desk of the New York Times started exploring and covering every single aspect of this enormous life-changing crisis in the country. And we did that, through data with all the maps that I'm sure you all have seen on the New York Times website, just tracking the disease and its spread. And then we've been tracking the legal, political dynamics of the illness, and just the health, the myriad of crises that this pandemic has wrought for the country. And we went into this piece thinking the nation is also experiencing a crisis of spirit. And what would it mean to really take a deep look at what that feels like, where is that taking place? How are families experiencing death? And what is lost at this time when there's this mass death, and yet all the tools that humans have created over generations upon generations upon generations, these rituals, what happens when the most intimate ways that we know how to process death are just stripped from us? And what does that mean on a personal level? What is that on a societal level? And it was very difficult to find a place in the country where some of these oldest rituals were able to take place at all, given the nature of the pandemic. And this team of priests, Catholic priests in Boston, was specially trained to anoint the sick in a COVID context. And that meant suiting up in all kinds of the PPE, working with hospitals and medical professionals in all kinds of ways to figure out just how do you anoint the sick, like in a way that involves physical touch. I mean, that's what's so powerful about that ritual for so many millions of Catholics, is being able to be touched touched by God through the priest in this moment. And so these priests had developed a way of, either by putting the oil for the anointing on a Q-tip, or at the dipping their gloved finger in it outside and going into the room and being able to read the prayers and administer the sacrament to the dying. And I think one of the things that would be interested in us talking about going forward today is, and this isn't so much in the story, but it was a real journalistic challenge to be able to even to show that this ritual is happening. If it was such a struggle for the priests to be able to get in, we were even one level beyond that. But I talked to priests and bishops, in I don't know, a dozen dioceses. Just trying to find where were priests even able to go and do this. And what we learned a lot is just how locked down hospitals were for legal reasons, and what that meant for the cost to the family. When we were witnessing families saying goodbye to their loved ones on Zoom, even that was very rare. Just to be able to coordinate everyone, allow this to happen in the midst of this huge crisis. And it was an enormous struggle of access for families. And I think it also put our observations was just, it also put medical professionals in this added position of being death's witnesses, even more in assuming this role that's been happening more increasingly over the last century, of whereas you could always count on a priest or a minister to be there with you in death. In the end, now, even like as a society, people's roles are changing as to who gets to do that. And I think that's something big picture that this pandemic is going to make us wrestle with in an even deeper way when we're on the other side of it.
So you brought up rituals. There's a couple ways I'd like to go with that. One, Elizabeth, I know that you've done reporting, not just on the Catholic Church, but other sort of church traditions or other religions as well. Curious if there's other ways that you've seen rituals change in the time of COVID in a similar way, and what effect that's had on sort of the worshipers. And then maybe for Ryan or Dan, curious from your perspective, both as sort of, ethicists and clergy, but also physicians, how you see the importance of rituals in the sort of medical context. So maybe start with Elizabeth, and then I'll allow that to open up to the other two.
Well, yes. I mean, this is a live conversation. I feel like, as religious holidays keep happening throughout the year in whatever form of liturgical calendar, they're going through, this is a live question that is being figured out in real time. I don't know that anyone really has an answer to it, but it is a time of forced innovation. I mean, it's currently right now we're in the Jewish High Holy Days. Yom Kippur is coming up. We just had Rosh Hashanah, and the thing that I keep hearing from people that I talk with is, what does it mean to be a religious community and to have to go through these most intimate things that are by nature communal? I mean, worship is communal in so many of these rituals and holidays and important moments in life. But how do you do that when you're alone? I mean, suddenly people are alone in their homes, not able to be with family members or with other loved ones, or just people that like who you do your life with. And so it's a real season of grief. I mean, we're seeing all kinds of Zoom, you name it, it's happening on Zoom in some kind of way. But at the same time of that innovation is happening, I think I'm noticing like a lot of real desire to be together. I mean, this is across any kind of religious tradition. I mean, because religion isn't just about these things, ideas you ascribe to. It's the most intimate details of how you structure your life every day. I mean, what does this mean for weddings, for funerals, for for anything? I mean, how you teach your kids, raise them up in the traditions of your family and of your religious community.
What about you, Ryan or Dan? Rituals, and you see people sort of at the end of life, what role can they play or should they play in terms of helping us process illness and death that maybe has been disrupted in this time?
I would echo much of what Elizabeth has to say, in that the pandemic is unmasking a bunch of the fictions that we like to tell about ourselves. Chief among them is the notion that the anthropology, the understanding of what it means to be a human being, is an isolated individual who is a rational thinker. And this exposes our irrationality, our fear, our passions, but also our profound interdependence. And the hunger that many people have to be together in the body. Again, there's something very dualist and something very disembodied about the rational thinking Enlightenment model of what it means to be a human, where the body is just something that sort of is attached to it in some way. But to live in an embodied way that incorporates ritual and the anointing of the sick and the taking of communion or the gathering of people for Shabbat dinner at the end of the week or the beginning of the week, All of these things are critically important. I wept when I was able to be back in a community that distributed the sacrament of communion, which it's happening to me now. Here I am, I'm welling up just thinking about that moment. It's become more consistent for me now, but the disruption of so many of the things that organize and interpret our lives have become much more magnified and much more meaningful. Ryan?
Yeah, I think one thing the pandemic has done is obviously broaden the impact that this is having on people. But as I reflect back to pre-pandemic times, I'm acutely aware that medicine has not done a very good job of making space for these sort of practices even prior to this, whether it's the baptism of a child in the NICU or the sacraments for a patient in the ICU at the end of their life on either extreme. So I think it's refocused our attention on this other aspect of what it means to be human, and has really challenged whether medicine is going to be able to carve out spaces for this part of our lives.
I'd be curious to hear you all speak a little bit about sort of why that sort of bifurcation exists. I know that, so Elizabeth had mentioned, much of what was driving it was sort of a concern with sort of legality, and sort of culpability. Are there other sort of drivers of that? And I know that, you guys kind of see it, especially you, Dan and Ryan, sort of, dual vision as sort of clinicians and people, more holistic people who have the sort of broader context. But, help us understand a little bit about why that is there in the first place, and how coronavirus has sort of maybe unveiled that.
I think modern medicine, despite its wonderful advances, is very focused on efficiency and monitoring and control of the body. I still remember at one point during my training when we were making ICU rounds, and we got to halfway through the unit, and we're about to enter the patient's room, and this particular gentleman who had days to live, he was Roman Catholic and was being visited at that time by his priest. And I remember our team just paused. We weren't sure what to do. Do we go on? Is the priest going to hurry up so that we can, talk about his respiratory status and his kidney failure and his antihypertensives? It disrupted our efficiency, our flow, and we weren't sure what to do with that. Nobody objected vocally, but you could see in people's posture that we were a little frustrated that, this threw a curveball in our otherwise, well orchestrated rounds for the day. So that's just an example of how, in modern medicine, where we're so focused on control and efficiency, taking the time to be with the patient, to be with the sufferer, and in these rituals, how there's often not space for that, and there's a dire need for that.
Dan or Elizabeth, do you have thoughts about that question?
Just thinking about, it really gets at this core question of what ultimately is it to be saved, or how is a human saved? And that is certainly a question that I hear from when we were doing the reporting about last rites, is, when the end is the end, who gets to decide that for the person? I mean, and then who gets to decide if the person isn't able to communicate that? I mean, these are the deepest questions that humans have. And when it's all coming to a head at this extremely charged moment, in every possible way, they're not questions that we've answered. like there isn't a set way we've answered that. And people have different capacities to be able to even face the question in general, much less in crisis. And then with all the layers of bureaucracy and need of all kind that people have.
Yeah, go ahead, Dan.
Well, no. If you want to move on, that's fine.
No, I'm not move on, but just sort of ask it in a different way. In one of your the articles where you're quoted mentions that you think that we should think about clergy in some ways as essential personnel in this time. And so I wondered if you could just sort of expound on that. Why should a hospital policymaker view clergy as essential personnel, and what kind of sort of justification do you bring into the argument for that?
Yeah. So that's a kind of a technical term, essential personnel, that in the context of my essay, I inherited from the folks that were making policy, at least at UPMC hospitals, but also at other hospitals around, that was restricting access to the facilities to those who were deemed essential. And we talked about who are essential workers and who are non-essential workers, which has a sort of hierarchy along these sorts of lines. And on the one hand, one understands the need to be prudent in paring down the potential exposures, either people coming into the hospital or the people coming into the hospital exposing the folks that are there to the virus or communicable disease. And yet, this speaks something to Ryan's point about efficiency. There are normative goods. There are goals toward which human beings direct and live their lives more than just the mere maximization of the length of their life or the functional capacities that they have while they are in life. And there are ways even to flourish or live one's life well as that life is coming to an end, or as that life has been divested of some of its independence or some of its capacity, and we all are sort of marching slowly to the grave. That's the reality of our condition. Though we live in a hospital and a research environment that sort of suggests that if the NIH were adequately funded and we had enough NIH randomized controlled trials, we would somehow get out of life alive in this sort of way. This is just not the way things are. So to suggest that an Amazon delivery person is essential, who is bringing in the things that the hospital needs, but that a clergy person is not essential, who actually has maybe not universally accepted responses to these large questions that Elizabeth were positing are being asked in precisely this moment, but at least have some facility in trying that. They've thought about these questions perhaps once before, and they have some tried and true over the century approaches to beginning to ask that. That is an essential work and job that needs to be facilitated in a way that the clergy persons have sufficient courage, as those that Elizabeth described in her piece were willing to constrain their own freedom and autonomy and live in a cloistered environment so that they didn't spread it out into the wider community. And that is the consistent witness of the churches, at least, and many of the Jewish communities, that when in the bubonic plague, the doctors were running out of the cities. It was the monastics and the Christians that were running into the cities, trying to live into the fullness of their calling to tend to the sick and the poor and the outcast and bind their wounds. That's and to be able, when medicine is being unmasked, perhaps for the first time in many of our memories, as being much more impotent than we like to acknowledge, to sort of acknowledge that even in the impotence of medicine, there are still things that can be done. They may not be efficient technologically and effective in the ways that we want them to, but there is value to sitting next to somebody and attending to their death.
We have a couple more questions that I'm going to pose to the panelists. I do just want to invite you once again, if you're watching, to add your own questions into the mix. Go ahead, Dan.
I would just say one other thing. In Pittsburgh, the hospitals are named Presbyterian, Mercy, Passivant. That's the name of a Lutheran pastor from the 19th century. St. Margaret Hospital. It is not a coincidence that these institutions which we rely on were founded by, and Montefiore Hospital, which was founded by Jews, by religious communities. So it seems to me the height of irony to exclude them at precisely the time that they are needed most. And it also unmasks the degree to which those religious communities have divested their responsibility for the care of the body to medicine in its professional guise. And there are real consequences to that divestiture.
Yeah, that's a great point, Dan. I got a question drawing on something that Ryan's written in one of his articles that maybe connects to that a little bit. Ryan, you wrote recently, the isolation we've experienced during the current pandemic has refocused our attention on the tendency of modern medicine to isolate individual patients. I wonder if you could tell us a little bit more about what you mean by that, and also help us understand how that insight changes the way that you practice medicine.
Yeah, that's an important question. You know, in our efforts to treat disease, we can't forget that humans are, as Aristotle taught us, right? Political animals, that is, we're social creatures. So to reemphasize Dan's point from earlier, the individualism that so permeates our culture is really a facade. And it's when our bodies are ill or frail that we are acutely aware that we need each other. A friend of many of the panel members, Far Curlin, who directs Duke's Theology, Medicine, and Culture Initiative, wrote beautifully that human beings are essentially embodied, dependent on others, and flourishing only when loving and being loved. The newborn needs access to the mother's skin, to her touch, just for normal development. The COVID patient needs contact with loved ones, not just us mass strangers. This is part of what it means to be human. And we isolate patients, you know, for the sake of technology. An example that both Dan and I experience frequently as surgeons is the operating room, but also the sterile ICUs, the COVID wards. These are extreme examples of the sort of isolation that takes place in the hospitals today. And in these settings, it's very easy to look past the whole person in front of us and reduce them to parts to be fixed. So in surgery, the patient is literally draped off so that all that is visible, all that we see is a part, right? Is a symptomatic area that we're working on. Or if you think about the ICU, the intensive care unit, the patient might be attached to a multitude of monitors and machines, ventilator, dialysis lines, maybe a heart-lung bypass machine. It's so easy to view them as a mechanical problem, something to be fixed, less than human. So certainly in this current moment, the isolation, the distancing we're all experiencing is an acute necessity, and these severe measures are needed. However, I really believe that this ought to impassion us to really lessen the isolation of the care for our patients once the pandemic's behind us. Can we reimagine the practice of medicine? Are we able to, as healthcare providers, to offer a tender gaze to our patients, to those who are suffering, not just a critical gaze at symptoms or radiographs or monitors?
How do you, if you don't mind me asking, how do you keep that in mind as a surgeon when the practices are sort of set? How do you remind yourself of that broader reality?
A few ways. I think one is entering into the room and trying to meet someone as a human, sitting on their bed, asking them about themselves, not simply skipping to go over the diagnosis or the blood counts or whatnot, but just taking time to remind myself that this person before me is a whole human being coming from a community, and they're looking for my help to restore them back to their work, back to their families, back to their communities, as well as incorporating into some of the rituals of surgery, of medicine, ways to refocus that. Before Dan or I ever enter an operation, there's a pretty lengthy process of washing, of cleansing ourselves before we enter the room. That's a wonderful moment to pause while we're doing that and reflect on the person that we're going in to help. Again, it's just not a sick gallbladder or colon. It's a human being whose community is longing for help to restore them.
It's also interesting that those rituals around the operating room table are in many ways identical to the rituals around the holy table of the Eucharist, and that the priest washes their hands and drapes out the table, and they both bear bodies and blood and flesh and offer hope of some kind of salvation in the midst of all of that. And that was brought home to me the first time in a trauma surgery when I was a fourth-year resident. The first time there were two people that needed operation at the same time and one fully trained surgeon in the hospital, and therefore I was stepping forward as the surgeon in charge. I was like, whoa, this is a different thing. And it dawned on me afterwards that I felt exactly the same way the first time that I stepped forward to the altar to consecrate the Eucharist for the first time alone. As a priest, I've been around both of those tables all of my life, but being responsible for it was a very holy moment, both times.
That's great. I'm gonna, I have one more question, but I'll save it toward the end. There is a question that's been submitted by a viewer that I wanna sort of pose to each of you. The question is, what would each of you say about the hospitalization of events that used to be sacramental or religious, such as birth or death? And specifically how the pandemic has affected our perspectives on these sort of life moments that now often take place in a sort of hospital context.
Yeah, as I've written elsewhere, it is not a coincidence that the medicine man, the shaman, and the priest are the same person in so many cultures, just from the anthropological perspective. And in our highly technical scientific world, the priests and the monks and the nuns are no longer wearing their special vesture, but damn it, we still wear flowing white gowns in the hospital as doctors, and we put these stethoscopes over our necks to show us that we are the ones in charge. And we live in a cloistered environment, and we preside over life and death and birth and these major transitions, though largely unaware that we are in fact filling a priestly role. And I think that the fact that we're unaware means that we're not doing a good job of feeding the need that we're suggesting that we're going to fill, which I think is part of the reason why there's such an explosion in complementary and alternative healthcare modalities that may not be as technically effective as allopathic medicine, but come attached to a cosmology or a worldview that helps people weave the experience of illness, birth, death, life, all of it into the fabric of their life in a meaningful way. That fundamental interpretive role is one that the shaman, the medicine man, the priest has been always dedicated toward, and being part of what I think Ryan and myself do slightly differently than some of our colleagues is that those ears and that set of questions and those eyes are constantly in the back of our minds, and we hear things a little bit different from patients. And rather than hearing, why did I get cancer, rather than responding with some sort of pathogenesis of oncogenesis of pneumocytes in the setting of tobacco smoke, we recognize that as being an existential question which deserves an existential response, and begin to probe and ask more questions and tease that out and help do that role of interpretation.
Elizabeth, that reminds me of what you said earlier about the sort of the role of physicians as witnesses now, and it's almost like a priestly role that is being sort of expected of them. I'm curious if you want to expound on that, or.
Well, I was just thinking about how this plays out in history, and it's so easy to think of changes just like in a few years or in these smaller ways. But when you look at like centuries, and it was interesting to me to kind of go back and see, okay, so in the Middle Ages during the bubonic plague, what happened to ritual, the role of the church, and I think, someone here might know more than I about kind of the origin of the modern hospital, but how these things like all played out, and these are huge shifts that take place over centuries, and these cataclysmic moments that affect literally everyone in a health event like a pandemic, happening at the same time that we have. Right now, 400 or 500 years ago, the major revolution in religion in Europe was the Reformation, and so these twin, and now over the last 100 years, in the United States, there's increasing secularization. There's just the decline in general of Christianity and Protestantism as the driving force in American society. And the way, like, I think it will be interesting to see how it's a matter of how these things intersect, and what the culture writ large, and what the institutions that drive the culture now, like the place of the church, if we're talking about last rites in Catholicism, for example, versus the place of the medical profession as these institutions that drive and kind of determine how we answer these questions, and also what people want. What do Americans want about how they live these what matters in birth, what matters in death, what is the demand for that? I think these are just huge questions that we're gonna be answering, not just now, but for how this plays out, in the years ahead.
Not just what they want, not to paraphrase Rumsfeld, but what people need. And particularly in these kinds of concerns and questions about which individual patients don't have much experience to inform their wants, there's something about attending to these aspects of life that both clergy and medical professionals are in a privileged position to have seen a bunch of different times, to begin to develop a sense of what people need, rather than just trying to respond to what they want or what they think they want.
And who the decision makers are about that. It's like many things, it's about power. There's the power in here, and who has control and who doesn't, and what is responsibility of people who have control for people who are vulnerable.
Yep, absolutely.
So one of the questions actually posed on that. So I guess I'll just sort of paraphrase the question. They were asking about the religious rituals that convey meaning and different presuppositions about health and illness, and then there's the medical rituals, and Ryan, you mentioned a couple of those in your answer. The question sort of was suggesting the possibility that these two ritual sort of groups of rituals are maybe fundamentally in conflict with one another. Is it a sort of religious or medical sort of divide in which the medical rituals typically overrule the traditionally religious rituals? Would that be a fair way of putting the matter, or would you want to sort of describe it differently than that?
I think that was to you, Ryan, right?
Sure.
It can be to any of you, but go ahead, Ryan.
I think that there is a false dichotomy where what medicine ought to really be about is fixing broken parts, the science, the technology, the efficiency, the control of the body, and things like spirituality, chaplaincy, art and medicine. Those are all secondary to our primary goal. Those are things that we offer because our competitor across the street offers that, and maybe they increase our patient satisfaction scores. But I still think there is this prioritization or privilegization of that the telos, the goal of medicine, is about restoring the body, and not to minimize that, but often it stems out of kind of a real dualism where the body is prioritized over the spirit, as opposed to if we really understand health, as it's, you know, as the word itself even means, to be whole, wholeness. It's the whole person before us, and as we've talked about, kind of the isolated body or parts is really a facade. So to be whole is to be restored to one's community, to one's faith community, to one's family. And so to simply view medicine as treating ailing parts really misses care for the whole person.
I want to jump in and say too, off of that, that, I mean, we kind of have answered this question. I mean, just look at as a society. I mean, in the pandemic, people who are offering religious rituals, and as well as family members, are not allowed into widespread. We're not allowed into hospitals, not allowed to be with the sick. What?
Except here at UPMC.
Right. Do something different. I'm sure families are grateful. But in general, I mean, the hospital administration decided, and not just that they're deciding on their own. I mean, the Department of Health and Department of Health and Human Services. I mean, the government, the federal government, issued rulings and regulations in some and at the state level. State health departments were making decisions. I mean, these were also political rulings and government decisions that are influencing who can go in and who can't, and what the liabilities are. So whereas 100 years ago, you know, I was reading an old Catholic newspaper from 100 years ago in the pandemic, or the Spanish flu, 1918, and the Catholic paper was talking about, you know, how priests are going to the sick beds day and night, and you know, and just 100 years later, oh no, they're not. I mean, that is not what we do.
So that was what I was gesturing at with this whole notion of how completely the churches and the synagogues have ceded their authority of the care of the body over to the hospital system. And I agree that it's distressing to me that the essay that I wrote didn't get picked up by any national media. It's now published. It's been distributed widely, but it has not changed the policy as it exists in a number of different places across the market. There are others that mimic some of what UPMC is doing in making it available, but I think it's instructive as much as my sense is that it's more a failure of imagination at the level of the person that's having to make the actual procedural decision. And I happen to be very privileged to be right next to the person who was making that procedural one and had fallen in the same line of everybody else about thinking along the narrow definition of health as Ryan was sort of articulating. And I just sort of said, wait a second, this can't be right. Really? Are we saying that we aren't going to let people who are dying and for which we have nothing more to offer them, we're not going to allow them the dignity of being attended to by their clergy? And asking that question allow that person from a human level to say, of course not. That makes you're completely right. How do we make that happen? And Ryan and I and all the healthcare professionals that are there, we're all taking risks all the time. We try to mitigate the risks and make it acceptable, both in the perspective of society and for us individually who are assuming those risks. And the same kind of approach can be put into place to allow people to move forward. But it speaks, as Elizabeth was saying, to how completely our culture has been transformed. That these questions take the serendipity of a weird unicorn like me, happen to be right at the position to be able to ask it in one context to lead to a different outcome. But I didn't have to push hard. All I had to do was just ask the question, and people were like, "Oh, of course." You know, when the focus moved from something this narrow to looking back, it's like, "Oh, right, easy solution."
So we've had a couple questions about sort of professional healthcare chaplains and the sort of institution of chaplaincy in the modern hospital, and be curious to know from each of you how you see that sort of role playing in our current way of thinking about spirituality and medicine, and maybe connecting the two or not. Any thoughts on the sort of professional hospital chaplain?
I've got a lot to say, but I'll defer to the others first before I get going.
I'll just say that in the reporting that when I was trying to work with hospitals and with families and with priests to document this story, I mean, it was the chaplains who were the link between everything at the hospital. I mean, the story, certainly I could never have done the reporting without them, but they were able to, I mean, they're under enormous pressure and they're so exhausted and so devoted, it seemed to me. But the way that they have to, and that they are able to weave between all these things, like weaving between family and medical care and the administration of the hospital, it seemed to be an unbelievably pivotal role for, I mean, I don't actually know what would happen without the chaplains.
What's Ryan?
Yeah, and I'll defer to you. I know you have a lot to think about on this topic.
So on the one hand, I had the privilege of functioning as a chaplain before I was ever identified as a medical professional. I did clinical pastoral education, which is basically boot camp for chaplains in hospitals, while I was in seminary before I matriculated at medical school. And that's always been a huge gift to be able to observe and participate in the culture of the hospital from that position, somewhat outside it, and not being identified as one of the practitioners. And I agree with Elizabeth that they have been and continue to be extraordinary linchpins, particularly now. My concern, and why I was focused very much in the UPMC policy initiative of getting community clergy to be recognized as essential, was that there aren't enough of them. Employed chaplains are increasingly a rarity, and at UPMC they've been staffing down, largely because everybody's margins are so tight that this thing that doesn't seem critically important or technically efficient in all the ways is less and less constrained. And yet there are lots of volunteer community clergy that are willing to come in, and as Elizabeth described, there are ways in which religious communities can organize the appropriate kind of volunteers to step forward with courage and grace to supply a need in these extraordinary kinds of circumstances. My concern a little bit, however, though, is the way in which professional chaplaincy, which now has its own sort of credentialing, has emerged, is it's quite subordinate in the ways that Ryan was describing to the ends and purposes of medicine, where the physician, who's the sort of head of that whole ship, will consult the chaplain when they have some problem that they can't solve and say, come here, you use your stuff to figure out how to get what I want to have happen with regards to caring for the body, rather than the religious voice being the one that is defining the ends and purposes of medicine or the ends and purposes of what it means to live. And as the chaplains have tried to be all things to all people in sort of a generic way and go in and provide some kind of pastoral support and care to those outside, not of just their denominational specificity, but completely different religious traditions, or to provide something that would be called pastoral care to those that are secular in their orientation. It waters down the power of any specific witness. It's still very important stuff to do because they are attending to questions that the medical personnel are not attending to at all, but it's not the same thing as having a Roman Catholic come and minister to a Roman Catholic, or an Antiochian Orthodox come in and do what the Antiochian Orthodox do for those folks, or just a milquetoast Presbyterian or Episcopalian like myself coming in and doing something that way too. Yeah,
that's very helpful, Dan and Elizabeth. We have about 7 minutes left. I'm going to pose a question that kind of comes from something that you wrote, Ryan, and also something that you wrote, Elizabeth. So in the article I drew from earlier, Ryan, you wrote, "Tragedy instructs us to accept the limits of existence, and the coronavirus is a reminder of our vulnerability and our finitude." And Elizabeth, you wrote that the coronavirus has laid bare human mortality and has forced a reckoning with the most intimate questions we have. So I think, so for our final question, I'd love for you all to offer your thoughts on what we might have to learn about vulnerability and finitude in our moment, and what impact you think it might have both on our national culture, but maybe especially on our medical culture. Do you see those lessons being learned, or are you hopeful that they might be? You can start whoever's most ready to respond.
Yeah, wonderful question, Travis. I think for all of us, the pandemic has really given us pause. Despite the amazing technological advances of modern medicine, at this moment, we're keenly aware that we're vulnerable, that we're mortal. Just this past week, I saw a news report of a young woman in Texas, otherwise healthy woman training to be an obstetrician, who died after she was infected with COVID while caring for others. It's a reminder during this time that we are mortal. Hopefully that reminder will refocus us, refocus our perspectives, reorient our tasks towards things that truly matter. In my essay that you're referencing, I interacted with Greek tragedy. Tragedy, I think, as a genre is really helpful because it reminds us that there are some sufferings that are unavoidable. And in fact, some of our attempts to avoid those sufferings can actually cause more suffering. And the example I used was Oedipus. It's an important reminder. So medicine, at the very same time that it brings much healing, can certainly and inadvertently actually become the means of our patient's isolation.
Elizabeth, can you expound on what you wrote a little bit?
I was just thinking of a woman I interviewed in the story, and she said, she's a professor of anthropology, and she said something like, this is a major disaster of the pandemic is going to change our relationship to death as a society. I'm not sure how it will yet, but it will, because this is just happening psychologically to us all. And I think we're in the middle of it. I'm not sure we know where this is going. But she's right. It absolutely will.
Dan,
I have two thoughts. The first is that, again, back to this sort of fiction that we like to tell each other, tell ourselves. We like to think that what we are is in control, and when we are our best. But I think that part of what mortality is unmasking is that what it means to be human. And so in medicine likes to try to alleviate suffering and make us as much as possible in control over our bodies. But both of those things break down in the end. And if we were to make it such that we never suffered and we were always in control, we wouldn't be human anymore, because what it means to be human is to suffer and not be in control. And the religious traditions are the ones that are the most real about that and have some response about how it is to live as a human being under those given limits, rather than a Sisyphean aspiration to be something other than what we actually are in our finitude, in our limitation. And the reward in that is that as much as I have I get great satisfaction from taking out a gallbladder that I know nobody else in the hospital could take out that gallbladder, because I'm the bomb when it comes to doing laparoscopic gallbladder operations. And Ryan has the same sort of thing. I don't derive nearly as much satisfaction from that as sitting down and helping a patient understand that they're coming to the end of their life, and that pursuing goals different than the ones of me just doing some technical operation are the ones that will lead them to make the best use of the time that they have left. Those pastoral skills which doctors engage, even though they don't have a white collar or an ordination certificate on their wall, we can all engage in that human kind of connection and help people be human beings and walk beside them and encounter and deal with their finitude and their vulnerability. That is hugely rewarding if people can see it and experience it and step into the discomfort that it initially appears to be.
That's well said. Thank you to each of you. I just want to thank you again for your generosity of your time and sharing your experience and wisdom and words with us and with the world. I also want to thank our co-sponsors again, the Carver Project at Washington University in St. Louis, and the Theology, Medicine, and Culture Initiative at Duke Divinity. And again, Anselm House, the Center for Christian Study at the University of Minnesota. We're really delighted to have this conversation. We're so glad you all joined us, and hope you enjoy the rest of your day. God bless.
Thank you.
Thank you.
Thanks, everyone.